Welcome everybody to the very first BioStock live event on Danish ground. We are here at the Crown Plaza Hotel in Copenhagen, and we have an interesting program today where we will get to meet no less than 9 companies in Denmark and Sweden. We have startups and we have listed companies, and we also have the benefit of having a larger guest today, that's Bayer Pharmaceuticals, which we are very happy. We present this in cooperation with Nyhedsbyrån Direkt and also Nasdaq Denmark, and we will also share this event live in one of Denmark's biggest social media investor groups, Aktieportföljen, which we're happy about. My name is Jonas Söderström. I'm the CEO and editor of BioStock, which is Sweden's leading digital news service for life science companies. I'm not going to stand here talking too much, so I would like to welcome today's first speaker, Dr. Ralf Ackerman, who is Cluster Medical Director of Bayer Pharmaceuticals. Welcome, Ralf.
Does it work? Yes, it does. Yeah. And I'm supposed to stand on the stage, I was informed.
That was perfect.
Yeah. Yes. Thank you, Jonas, and thank you for inviting. And I don't know, there's a bit echo. For inviting to this exciting event. I read the headline. It actually said, "Connecting innovation and capital." I think it should be connecting people. So I think that's a great opportunity. I represent Bayer, and Bayer is a group of divisions. One of them is pharmaceuticals, and I'm coming from that division and representing Denmark, Norway, and Iceland in my role and function. I'll come back to that a bit later, I presume, in the interviews. But that's where my responsibility lies. So what I will do, I will give you a quick overview on Bayer as such, the whole group, just to give an introduction. Who is Bayer? What are we working? What is our focus? And also, where is our interest here in Scandinavia, especially, of course. So let me see if I can have this way. Yes. So, and I've made a little presentation in that context. I think this is dangerous to stand here on the corner, but you have insured me, so that's good. Yeah, okay. Actually, we are not just a pharmaceutical company, as I mentioned. We are a life science company. And that's also why we have our logo, Science for a Better Life. And that is because we actually are involved in all matters that actually relate to life. And that is the pharmaceutical business as such, with drugs and medicine for human beings, but also for animals. We also have a division where we work on crop science and on seeds and compounds as such. So we are truly a fully encompassing company acting globally. And as you can see, a growing and aging world population requires an adequate supply of food and improved medical care. And that's actually where we act in. This is the area we are functioning within. As mentioned, we are consisting of 3 major divisions. There is the prescription doctor pharmaceutical area. There is the consumer health matter, which is consumer health drugs for various indications, specifically dermatology and dietary products. And then there is the crop science matter, which is in agriculture, products that relate to this and secure that we have food across our globe. And then finally also products for the health of animals as such. So this is the big group, Bayer Group, consisting of these 3 divisions. If we focus a bit, just very shortly, on what is Bayer actually, these are some figures from 17, the 18 ones I do not have yet, but it's just to give an impression, where are we here? Around 35 billion euros in overall turnover for the whole group. Today we're around 105,000 employees across the globe. We're represented in most countries in the world, and we have heavily investment in research and development as such, above the 10% of our overall turnover. So that's how Bayer overall looks from a very overall financial point of view. What of course is important is research and development in any company working in a life science area. That is our true commitment, and we are an innovation company, as we also like to name ourselves. We are truly dedicated to innovation, and therefore research and development is one of our key drivers, not only for being here today, but also for being here tomorrow and the future. That is very important for us. And what you see illustrated here are the divisions I just mentioned, and how much just overall, from an overall perspective in percentage, they invest in research and development. And as you can see, the pharma part is the largest one in relation to overall investment, above 50%. And in total, as I mentioned before, 4.5 billion euros. Now we focus a bit in again. So here we stand in Denmark, but the Danish affiliate, which is actually just across the street, over in Arne Jacobsen's Allé, that's where we are situated and handle the Danish business and functions as such. But we are part of a Nordic region here in Denmark. So our overall management, you can say leadership, is sitting in Stockholm, and also we have in Turku for some of the other countries overall. So it's 8 countries, 10 Bayer sites, and around this number of employees. Just to give an impression, in Denmark we have a turnover of approximately 120 million euros, and for the whole region as such we're around 300 million euros as far as I remember. We have both administration, of course, but also research and development facilities, and also production here in Scandinavia, actually in Oslo, as you can see, and in Finland, Turku. So let's just focus a bit narrower now. Let's go into the pharmaceutical division part of Bayer. A few figures from 17, close to 16 billion euros. Our headquarter for the pharma part is situated in Berlin. For the rest of the company is situated in Leverkusen, which is more centrally positioned in if you look geographically of Germany. It is actually Germany's largest pharmaceutical company. And as a number of interest, I can tell you, if you look at prescription drugs and turnover in Denmark, just small Denmark, we actually number 3 pharmaceutical company right now, according to that figure. So we are very, you can say, well situated here in the Scandinavian countries and also here in Denmark. We have focused on prescription drugs in the pharmaceutical part, of course, and I'll just give a very small glimpse on that in a minute, and also address a matter such as medical imaging, and that is contrast media in relation to MR scanning and CT scannings also. So I think this also very quickly gives you an overview how big and what a big portfolio Bayer as such overall is addressing. And that also is therefore interesting for us to be part of this ecosystem in this kind of meetings and meet you as speakers, or meet in one-to-one face talks, or listen to your cases, because we're always looking out for something out there. We are not interested in Me Too products or generics. We are working with innovation. We are extremely committed to that. The overall figures, I think, should illustrate it, and that's where we're going. So therefore, we are happy to join an event like this also. These are the overall business areas within pharma, and the biggest one is the cardiovascular and the oncology area. The cardiovascular, especially coagulation matters. It is hypertension compounds. In oncology, it's prostate cancer mainly, it's hepatocellular cancer, it's certain kind of blood type cancers, and also colon cancer. In ophthalmology, mainly focus on the macular degenerative diseases which may risk to people becoming blind. So it's an extremely important area we feel where we contribute. We believe to many people avoiding this debilitating stage. Gynecology, we have a big commitment also within this, especially today now in intrauterine devices in various versions for various parts of the female population. So there also a big commitment. Hemophilia, we are committed within hemophilia A, one of the hemophilia disease stages, and we have several products there, and just also recently launched and work on compounds that even further address the convenience for people living with hemophilia, and that means they have usually to inject them once a day or every third day, but you can even do it better, and that's where we are working on also. And then we have other illnesses such as the categories as you see out there. So it is a very wide portfolio. But overall, you can say the main drivers, looking also in the future, are the cardiovascular oncology area and also the gynecology area. So that's where we are. Yeah. Looking at research and development and the future, we are looking at areas, as I mentioned already, the cardiovascular part, further expanding our portfolio, further providing even more support to lives, to patients and relatives out there living with diseases within the cardiovascular area. The oncology is an extremely high commitment for us, where we are part of, you can say, all kind of interesting collaborations with institutions, governments, other companies, working on gene technologies, CRISPR technologies, fusion tech, whatever. We are exploring and identifying relevant compounds there also now and in the future. And the gynecology part, as I mentioned also. I don't have time to go into more detail because it's a very short, Jonas, as you said, a time limit I have, so I'll just have to jump in further, but it's just to give you an impression. And of course also the ophthalmology area and the hemophilia area, which I just mentioned to you, to even further improve the convenience of the compounds within this. Again, we are a truly global acting company. We have several units across the globe, all over from US to China and Japan, and they address various matters within our discovery portfolio, and you can see the number of employees related to this, and also some of the figures. So no need to go further into detail, just to illustrate again, we are a truly global player. I just look quickly on some of the figures, because what relates to all what we are discussing is of course also publication and studies and sharing all this knowledge. If you look at clinical.gov, I mean, it's maybe as expected, but it is truly an exponential growth you can see in publications. This illustrates the overall publications, studies registered over time from this year, from 2000 and up to 2020. So this is a tremendous amount of information and data to digest. What is interesting was to see how many studies right now actually also recruiting, how many patients, how many doctors, institutions, pharma companies are involved. And it's the interesting is the distribution between US and non-US actually quite equal there. So that's also interesting for us. So we are definitely in the race, and also just here in Denmark or in Scandinavia, we have more than 60 studies running within Bayer Pharmaceutical here in Scandinavia. And in the end, it's also about money and investments. If you look at the American Association of Pharma members and their 30 biggest member companies, which are global companies, international companies, you can see it's only going one way, the investment trend, and that's up. So of course, it's a challenge, because the reimbursement situation and the situation in relation to launches in the countries is getting extremely more complex also and difficult. So it's more and more challenging. You have to show more and more value once you launch. So that is truly a challenge. Just to illustrate, we are working with many stakeholders here in the Nordics and in Scandinavia Just to mention one, our Stockholm headquarter, which is right now located one place in Stockholm, we will actually move very soon to Karolinska Institute University Hospital, where we actually situated there with our offices. You can't get closer to the scientists than that. So that we're looking very much forward to. But just to illustrate again, we collaborate with a lot. Then we have these innovation centers. I mentioned innovation is a truly commitment for us, and we have innovation centers which nurse, you can say, the relationships locally, regionally, with the various stakeholders, such as you sitting here. So that is also, again, a true commitment, and as you can see, we even have here in Europe, in Berlin, we have a center concerning that, which has guests from foreign parts, works together with other companies and stakeholders here in Europe. This is the portfolio in relation to innovation initiatives. Again, no time to enter into detail for all of these, but one I would like to focus a bit on is one that is a lot of interest around these days, is the digital media and science and social media, the grants for apps, which is one of our initiatives, and then we have several others, which in the end all is about collaboration and all putting people together, working on some interesting compounds, ideas, data, and nursing this. That is really important for us. I don't know if you know this, but that's actually interesting. If you look at the internet, just for 1 minute, 60 seconds, what happens on the internet right now, let's say in the next 60 seconds? I mean, it says 18 million text messages, 187 million emails sent, tweets, and it's a lot is going on there. And why am I mentioning this? Because this is also relevant for us working within the pharmaceutical industry or the life science area. Because this media is here to stay, and we have to work around and see how can we get into this in an intelligent and way that supports, you can say, the vision that we have as a company. And the numbers, I cannot even spell them out, all these zeros there. It's incredible. So it's just to give you a view on that. And with that in mind, actually, we have the two programs, grants for apps, applications, and grants for apps, Dealmaker. One is the newcomers, and the newcomers into the others are more the established one. And just to mention one example where we actually have an outcome from this kind of collaboration, it's a so-called Quatrium initiative. And very simple said, they developed an application which was linked to a device which monitors the heart rate and the rhythms around this. And this is then visible to the user or the doctor, whoever, on an I think iPhone or computer or whatever. So this was a new technology which we initially supported, and this actually generated a product and something that today can help patients monitor their health stage and do it even better. So let me end with a quote. I like quotes. So who is this guy? You know who this is? Yes, you know, it's Charles Darwin. And more than 200 years ago, he always said, in the long history of humankind and animal kind, those who learn to collaborate and improvise most effectively have prevailed. And I believe that's our challenge of today in where we act, because there we have to improvise and we have to collaborate. And that's one of the matters we're actually doing today, collaboration and meeting people. So with this little intro, which was extremely short, I hope it gave you just a small glimpse on what the Bayer Group is, what Bayer Pharmaceutical is all about. And then I presume I will meet many of Sina and I, who's also from Bayer. We will meet you later, so we're looking forward to that. So thank you very much. Yeah.
Thank you, Ralph. Very interesting. As you said, there's not that much time now, but it's interesting you had the opportunity to mention the different collaboration programs. And of course, like you said, the companies that are here to present today will meet you and seeing the communications manager of Bayer in individual meetings after this. So yeah, thank you very much for now. So it's a pleasure to jump forward straight into the program presenting startups. And next up, we have a really exciting, actually a close neighbor of BioStocks in Lund at Medicon Village. From the Smile Incubator company portfolio, we have Saga Diagnostics, who develop an ultrasensitive cancer diagnostics. Please welcome Lau Sal, CEO.
Okay. Good morning. I'm very happy to be here. My name is Leo Saul. I'm the co-founder and CEO of Saga Diagnostics. It's a pleasure to present to you our company, and the slides were not up. Our company, Saga Diagnostics, we are a 3-year-old startup company, a spin-out from Lund University. We are based in southern Sweden, and we focus on cancer diagnostics and a very exciting area called the cancer liquid biopsy. So we all are well aware that cancer is a huge problem, but I want to draw our attention to a number of issues that our company is addressing. One is that the current standard of tissue biopsy is actually insufficient. It has risk, it can miss the tumor, it can lead to complications. Today, it's also very difficult to measure how a patient's actually responding to therapy. The best imaging and tumor markers today are not sensitive and specific enough. And what this means is that many patients who develop recurrence of the cancer, this is detected much too late, and pretty much across all cancer types, metastatic cancer is incurable. At the same time, there's a well-recognized issue that many patients are actually being overtreated. This is sort of the flip side of the coin, where patients who have low-risk cancer go on to have very my mic went out, or it's back. Very toxic therapies that they don't actually need because they are cured by the surgery and local therapies. And finally, it's well known that drug development is quite expensive, in particular within oncology. So the solution to this, we believe, and I think many in the industry believe, is in large part the liquid biopsy and the circulating tumor DNA biomarker. This is very simple to collect from normal blood samples non-invasively. It's quantitative and gives a readout of is there cancer in the body and how much cancer is in the body, and also which mutations are present, and many new therapies target specific mutations. We and others have shown this to be very prognostic and also predict which therapies will work. And we can detect metastatic disease in some cases up to 3 years before it shows up by standard methods. We think that this can be used in the future to spare patients from toxic therapies if they're already cured, so we give the right drug at the right time. And through a combination of these effects, we believe that this technology can accelerate drug development and help drug developers to conduct clinical trials and learn from more from their patients and optimize their future drug development plans. So what is circulating tumor DNA? This cartoon on the left shows tumor cells, and the ctDNA is little bits of DNA which escape from the tumors into the bloodstream and mix with all of normal DNA that everyone here has also in their bloodstream. And because it's a mixture of both tumor DNA and normal DNA, one needs very specialized technologies to detect this. We use the tumor-specific mutations and the rearrangements of the DNA chromosomes as biomarkers for a patient's cancer. So we have 3 innovations that address and detect these biomarkers in different ways, which I will not go into today, but to just jump ahead, these are the highest performing technologies out there, proprietary and patent pending. We have very good validation data, and essentially all cancers release this ctDNA, so it can be applied to any cancer type. Even Forbes has recognized liquid biopsies as a disruptive technology for healthcare by 2020, and I think that's actually not really that much of a exaggeration. This can be used in many areas of oncology. It's a nice figure from Nature. And as a company, we are focusing on the part once a patient has a cancer diagnosis. So how can we profile this cancer better and to know if it's a high-risk or low-risk patient? Can we detect if there's any residual cancer after surgery? How is the patient responding to therapy? And can we detect metastasis and tumor evolution over time? We can do this better and faster, cheaper, and also at scale compared to competitors. And one of the main features is our ultra-sensitivity. And what this really means is that we are about 100-fold more sensitive than competing technologies. And a key figure is this lower limit of detection. That is, what % of the DNA has to be mutated from the cancer for you to detect it. And so we can detect the smallest amounts of DNA from the tumor at a much higher sensitivity than the competition. We can do this very rapidly within just a couple days of receiving a sample, very cost effectively, and also we can make this into kits for wide distribution to labs around the world. This addresses many customer needs. First and foremost, the patient. We can get better diagnostics to them more comfortably so they get the right treatment. Of course, physicians and hospitals want to give the best treatments for their patients. Health insurers want to reduce costs, so you don't want to apply therapies if the patients don't need them, so you can save cost. And pharma companies, of course, want to find more patients that have their drug target. They want to conduct their therapy, their trials more efficiently. The market for this is very large. I apologize that there's something with the slides on this computer, but in Europe, we estimate the market to be about 9 billion euros. Piper Jaffray Investment Bank estimated the US market to be about 6 billion euros. So together, this is about a 15 billion market opportunity in just these 2 markets alone. We are focusing initially on breast cancer and lung cancer, 2 rather large diagnoses that represent over 2.5 billion euros per year. Our business model has sort of a stepwise progression where we operate a central service lab and actually have early adopters already sending us samples. We also are partnering with other labs to set up our technology in partner labs to offer to their customers and their patients. And through this activity, we get some cash flow. We accelerate our own internal R&D and gain insight into the customer base, which feeds into the long-term development of CE IVD marked kits for sale. So the sales matrix for this, our approaches are very large with our 3 different technologies, which have different benefits in different situations and the many different types of cancer that there are. So this market that we approach initially will, of course, expand as we grow as a company. We have a terrific team. Myself, I have an MD and PhD background from top institutions in the United States, like Columbia University, NIH, and Sloan Kettering. I'm actually a cancer survivor myself, so I have a real dedication and passion to bring our technology to benefit patients. Our co-founder is Anthony George, who helped develop the technology. Åke Nilsson is our BD director. He's here in the audience. Please come see him if you have any questions. And Carolina has many years' experience with clinical diagnostics. We have a terrific board of directors with expertise in startup companies, in taking companies to the stock market, IPOs, entrepreneurs, BD, as well as Henrik Winter, who's a veteran within cancer diagnostics. We also have a very good scientific advisory board. I can mention that Dr. Boris Sandale is the former president of the European Association for Cancer Research, so she's one of the biggest names in cancer research. And Nicholas Lohmann has been head of diagnosis of a number of diagnoses for the southern part of Sweden. We're also part of a very interesting and helpful network called Noman, and have advisors who are very esteemed. Carl Borbeck started many companies, Peter Benson within venture capital, and Alva Kaikkonen, who has founded a number of medical device companies. This is a very hot area. We're not the only player. There are quite a number of them, and there's been a number of acquisitions over the last few years. I won't go through all of these, but several have been acquired by Roche, for example, for over $1 billion US. This is a kind of busy slide, so I won't step through all the details, but we of course, have a good sense of what the competition is and can see that we have a quite unique position in a number of key areas. Our development plan spans over a number of years, and we are doing quite well. I won't step through all of this other than to say that we raised capital last year and will raise more money this year and are already talking to a number of different types of investors. We plan to initiate our own clinical studies towards the end of this year to further establish particular technologies as part of clinical practice. Just to give us some recent highlights, we are quite visible within the field with many presentations, including TV appearances and so forth. So people are very aware of us within pharma and academia. We've won a number of awards. As I mentioned, we raised seed capital last year of about 1 million euros. We've also received a number of grants from the Swedish government. And for example, I've been named a top 7 finalist in a startup competition of over 4,500 entrants. Our IP situation is quite good. We expect our first granted patents to come in the first half of this year. We've filed in 14 jurisdictions around the world. We're expanding. We're hiring more people right now. We have a number of early adopters. I'll mention just a few. We have a Swedish hospital partner that is evaluating our technology for use with patients. And we have a number of rather big name industrial customers. We've been chosen to participate in a phase 2 clinical trial with Wint Research, a Swedish biopharma company. So with that, I'll summarize that we are a young and dynamic company that is really on the right track. We're very motivated to bring our technology to benefit patients. We spun out from successful research at Lund University. We have these superior methods for detecting circulating tumor DNA. We have market traction and a good development plan. We have this 3-part business model with a service lab, lab-in-lab partners, and then kits. The market for our technology is very large. We are raising capital this year. And we foresee that as we execute successfully as we have, we may be an attractive acquisition target. And certainly we are thinking about future raises, whether it be through a Series A or even going on the public markets. So with that, I thank you for your attention, and I'm happy to take any questions.
Thank you very much, Lau. Seeing that we have a press program, we don't have that much time for questions right now. I just wanted to ask really quickly then, at the point where you're at, you mentioned that you're raising capital now in 2019 as well. At what level are you raising capital? How much do you need, and what are you going to do with the money?
So, as I mentioned, we are planning to do a number of pivotal clinical trials of our own to launch towards the end of this year. So we are planning those out and establishing the budget. So I don't have an exact number, but it'll be in the range of around 5 million euros.
Okay.
Yeah,
that's good. Like Lau said, you are very welcome to talk to the companies in the breaks and ask your questions there. So say thank you very much for now. Thank you. Next up, we actually have another neighbor of ours from Lund Medical Village, and also a Smile Incubator company, portfolio company, sorry. Gidea Biotech, and Annette Savon, CEO, will present for us right now. Welcome.
Thank you. Hi, my name is Annette, and I'm the CEO of Gidea Biotech since 2 years back. 12 years ago, I actually finished my PhD just over the bridge in Lund, Malmö, and was the co-founder of just that company, which Saga mentioned, Wind Research, which is now in phase 2 trials and a listed company. But 2 years ago, I joined Gidea Biotech, and Gidea develops the first treatment on the market targeting both bacterial and fungal vaginal infections, and yet being antibiotic-free. And I will tell you more about this now. So, globally, we have at least 400 million women having at least one vaginal infection a year. Many patients suffer from recurring infections, coming back at least 4 infections a year. So the infections greatly affect the ability to go to work and family lives and activities, and influence the quality of life. Currently, there are different treatments for bacterial vaginosis, BV, and vaginal candidiasis, the fungal infection, VVC. And for BV, if you go to the gynecologist, you are most likely prescribed an antibiotics, local antibiotics. And if you have recurrent infections coming back, you are prescribed antibiotics on a regular basis as a prophylactic. Vaginal candidiasis is mostly treated with vaginal mycotic treatments, and if you have recurrent infections, you're standing on continuous oral antifungal treatments. So there are existing treatments. The main issue is the recurrence of these infections, which is up to 50% of the patients get their infection back within a couple of weeks or a few months. The recurrence has many reasons, but two of the most important reasons is the use of antibiotics, which also kill the normal protective bacteria. And that increases the risk of having a bacterial infection again or a candida infection, so they greatly interfere. Also, the biofilm, which is kind of formed by the bacteria and the fungi and protect the bacteria and the fungi from the treatment, makes the treatment up to 100 times less efficient. So the bacteria and the fungi hide below the biofilm, and that is another reason for the high recurrence of these infections. Globally, we also see the high threat of antibiotic resistance, which we all are aware of, and we need to reduce the unnecessary use of antibiotics. So vaginal infections can be mainly caused by fungi or bacteria, but they are also quite often mixed. Up to 1/3 of the infections are mixed, having a presence of both bacteria and fungi. And for those treatments, for those infections, we don't have any good treatment today. Most women go to the pharmacy and buy an over-the-counter treatment as their first-line treatment. But the symptoms of the bacteria and the fungi infection can be very, very similar and hard to distinguish. And in fact, it's shown that 67% of the women buying an over-the-counter treatment choose the wrong treatment. because they misinterpret their symptoms. GIDEA developed a solution to this. We call it FIF. And it's one treatment, a local treatment, for the cure of both diseases. It is antibiotic-free, which means that it will not affect the normal flora and protective bacteria. It removes the biofilm and restores the vaginal pH. And these three features, that is antibiotic-free, removes the biofilm, and also restores the vaginal flora, makes us estimate that we will have a lower recurrence upon this treatment. It has a documented safety profile. The ingredients have growth status by the FDA, and in Europe it's considered a medical device, so we have a short route to market. So the mechanism of action, so bacterial vaginosis occurs upon a pH rises, and you have a bacterial imbalance, which is showed by the red in the middle. What FIF, our treatment, does is that it breaks down the biofilm and thereby accesses the bacteria and lowers the pH. And in that way, it stabilizes and restores the normal vaginal flora. So it doesn't affect the normal protective bacteria. It just restores the vaginal pH. On the Candida, upon a fungal infection, the fungi, or Candida, adopt a form called hypha, and that is the infectious form. So these hypha, the long protrusions, are responsible for the infection, and they are also responsible for forming the biofilm. And what FIF does is that it breaks down the biofilm and accesses the bacteria and the fungi, and it reverts the fungi from this hyphal form to the non-infectious yeast form, and thereby restores the normal vaginal flora. It's important to mention that it doesn't kill the Candida, which means it reverts it to a normal form, which is normally present in the microbiome. And this means that in the mechanism, there is no selection pressure and a low risk of inducing treatment resistance. Because treatment resistance occurs when you kill most of the microbes, but not really all, and the remaining get stronger. This doesn't kill it. There's no selection pressure, less risk for resistance. So it has a dual action, and for the consumer, this is an apparent, obvious to get the right treatment immediately. Also, it's important for the consumer to reduce the risk of choosing wrong and thereby having to wait for a good result and symptom relief. And it's important that it's antibiotic-free. You see in publications that especially the patients having the recurrent bacterial vaginosis, having this constant antibiotic use, they are very unhappy with having antibiotics. So antibiotic-free is important for the customer. We have extensive in vitro data showing the effect on bacteria and on Candida and on different Candida species, on biofilm, and also that we save the normal protective bacteria. We also have 3 patent families protecting the invention, and 2 clinical trials ongoing currently, 1 in vaginal candidiasis and 1 in bacterial vaginosis. Each of these studies include 24 patients, and they are run in the southern part of Sweden. And we expect data readout in March, so in 2 months' time. Based on these 2 studies, we estimate to have a CE mark of this product, approval for Europe in the end of this year. The market exceeds €1.5 billion annually for vaginal candidiasis and bacterial vaginosis. There is a high unmet medical need, especially with the current infections, and it's an expanding market. Currently, we are a privately held company. We have raised 4.5 million Swedish kronor in grant financing and about 21 million Swedish kronor in investments. So we are well financed at the moment. And our next step is to confirm these initial data which we are getting from the clinical studies in a larger control studies. And our primary objective is to do it in a partnership. But we are also open for the possibility to have an investment and performing the clinical trial ourselves. In that case, an investment of between 3 and 5 million euro will be seen during 2019. As I mentioned, our strategy is to find a partner for clinical trials, but also for launch on the European market already next year, and continuously on the global markets. We have confirmed interest from several major players in women's health and over-the-counter treatments, so there is a confirmed need for this treatment. The company was founded by 4 chemists and 1 senior physician in gynecology at Lund University, a spin-out. All of the 4 founders are highly engaged in the company still, and I would like to mention Helena Strevens, senior physician in gynecology, meeting these patients daily at the Lund University Hospital and responsible for the clinical trial strategy. I would also like to mention Olof Sterner, who's here in the audience. He's a serial entrepreneur, and this is his most successful company thus far, I think. About 10 companies he's been founding and exited a few of them, so he's been through the journey before. Professor in bioorganic chemistry. In the management team, I'm accompanied by a strong regulatory competence in Manas, to the left. She has been working with medical device directive for a long time and responsible for the CE mark procedure. I'm also accompanied by Eva, who's here in the audience as well, having a background as a key salesperson within vaginal infections in large pharma, so she has a profound knowledge in marketing of these types of products and market insight. Among the board and the owners, we have a very strong life science and pharma competence, and this is exemplified by 2 of the board members, Mats Persson, previous general manager for Astellas Pharma, and Kerstin, who's responsible BD person at Nycomed for the $13 billion deal with Takeda. So, in summary, we have a strong and very committed team. We have a product ready to enter the market end of next year, and a large unmet medical need. As an external validation of our project, we have received Horizon SME Instrument Phase 1 trial grants. So join us as an investor or partner and make a contribution to global women's health.
Thank you very much.
And I'm happy to take questions.
Yeah, this one we actually have time for a few questions. If we have any questions in the audience, welcome.
My name is Hanson. So, do you envision that this will be a standalone treatment or rescue treatment from the other available treatments, or what's your view on this?
I envision it as a first-line treatment, because then as an over-the-counter treatment, it's also possible to do it as a prescription medicine. The partners that we have been in discussions with thus far has promoted the over-the-counter treatment, because that's where you have the most benefit for the patient. That's the first-line treatment, reducing the risk of choosing wrong and having a shorter way to alleviation of the symptoms. And in the bit longer term, I envisage also that it will be used as preventive measure for the recurrent infections, but on a lower dose but on a regular basis, because it doesn't affect the normal flora, so there's no harm. It's just stabilizing.
We have another question in the back, I think. Perhaps you can repeat the question so it can hear you.
Sorry. You said you were looking for medical approval as a medical device in the EU. Has it been approved? And if so, which class device is it?
So the question is whether it has been approved as a medical device and which class. So it's a class 2A medical device in Europe, and it has not been approved yet. We are basing it on clinical data, and the clinical data we will have in March this year, and we estimate to have the approval, the CE mark, in the end of this year. So that in the end of 2019, we estimate to have an approval for Europe, and then we will, based on the clinical data, work also forward towards an approval in the US.
If I can just add on, based on the presumption that you do get approval, what time would you say, how long before you're on the market?
Depends much on because our primary focus is to find a partner for marketing and launch. At least half a year will it take before the pharmacies have their time to take in new products, and so during mid 2020, I would say.
Great, we're looking forward to that.
Yes, and the patients as well, they're lining up.
Of course, yeah, a huge need for that. Thank you very much, Annette.
Thank you.
Warm hand. So that marks the end of our first session. We're going to have an opportunity to take a break now and have some nice coffee and perhaps something to nibble on. And we will join back here at 11:10 for the next presentation, which is Cereno Scientific. Enjoy the coffee. Thank you. We are all ready. Okay, welcome back from the break, everybody. I hope the coffee was tasty and that you all feel very refreshed. We're going to go ahead with the program. We've heard 2 very interesting presentations so far. Sorry, 3, including Ralph from Bayer. Now, next up, we have Cereno Scientific and Sten L. Sørensen, CEO of Cereno Scientific, will present their project in thrombosis prevention. Welcome, Sten.
Thank you. Hello, everyone. I'm delighted to be here and to share our vision at Cereno Scientific and developing a new drug that we hope can prevent thrombosis in an effective and safer way than those drugs available today. Okay. You go. Sorry about that. So the company is Cereno Scientific, and we are focused on one of actually the biggest killer on the planet, thrombosis, and it manifests in myocardial infarctions in the heart, in the brain as stroke, and also in the veins as deep venous thrombosis and so on. And risk factors for thrombosis are many of the common welfare diseases, so to speak, so diabetes, high blood pressure, previous infarcts, and so on. So it's a very common risk factor profile, and it's the most deadly event on the planet if you don't count infections, etc. Now, every second somebody dies or gets in thrombosis, and more than 10 times that gets in thrombosis and survives. So it's a major health problem. If you survive, you might have a damaged brain with disabilities, or you might have developed heart failure. So it's a major thing. Now the market, of course, is then very big. So it's currently around $20 billion, and it's expected to double within 7 years to $41 billion. Now, the current treatments are involves serious risk of bleedings, and the reason for that is that the actual mechanism of action weakens the coagulation process. That's how they work. So there is a need for more safe therapy out there. And the reason for that is that you want it to be more safe, but because the drugs has this serious side effect, you can't really optimize the therapy. Because if you increase the dosages, you have more risk. So the efficacy could be much better. So within 5 years, 20% get a new stroke or a new thrombosis. Now, if you look at the side effects here, and this is from clinical materials, up to 2.5% of those involved in clinical trials get a serious bleeding. Now, and up to 25% get any kind of bleed, and that can be nosebleeds doesn't stop, so you have to go to the hospital. That's 1/4 of the patients. So there's a job to be done to improve therapy. If you look at how the body handles a bleeding, that, for instance, a plaque that bursts, it has a coagulation process, but it also has a fibrinolytic process. So if there is a bleed, the body wants to stop it, but it doesn't want the vessels in your body to be occluded. Now, all the drugs out there, as I mentioned, are attacking, so to speak, or the mechanism of action is to weaken the coagulation process. And that's fine, that's what's available today. Now, Cereno is working very differently. We are approaching the fibrinolytic system of the body. And the reason for that is that in risk individuals, that's weakened. So there's a much higher risk of thrombosis in those patients. Now, so if you take the current drugs, you weaken the coagulation system and you increase the risk of bleeding. If you approach the fibrinolytic system, which is weakened, you improve the body's own defense mechanism to dissolve the clot before it gets occluding. So you reduce the risk for strokes and infarcts. If you look at it another way, this is a cut-through vessel. It's a plaque, atherosclerotic plaque, the most common cause of bleeds and thrombosis. And what happens when a plaque bursts, there are signals going up to the endothelial cell wall, and in that wall there is a fibrinolytic substance, the body's own substance, TPA, a protein. That's released to dissolve the growing clot, that blood clot that is forming. So it's a defense mechanism. There is another protein in the blood floating around, and that's pi. It's the main inhibitor of TPA. So this is how it works normally in the body. The problem in risk patients is that TPA is very scarce in the endothelial cell wall. So like the sprinkler here, if there's a fire, there's no water, or very little. So the fire gets on. And the same here, the blood clot can grow. The other negative aspect if you're a risk individual is that pi is very high, especially in the morning hours, and it's not a coincidence that that's when the stroke and myocardial infarctions are most highest incidence. So if you look at this in another way, so this is a coronary artery, you see the heart, we cut it through. In a normal patient, if you have a small bleed from an atherosclerotic plaque, TPA is coming out, pi is low, so it doesn't really block it. In a risk individual, you have the same kind of bleed, there's no TPA, so it can't dissolve the blood clot before it gets occluding. And pi is very high, so whatever TPA is coming out is blocked by pi. So it's an increased risk situation. What can Cereno do about that, or our drug? Well, if you use our drug, you can improve or restore the defense mechanism. How is that? I'll show you some slides of documentation. But actually, our active compound, increases the synthesis of TPA, increase the storage of TPA and the release of TPA from the vessel. So the water is there if there is a bleeding. We also have shown that we reduce pi with up to 50% in the bloodstream. So we actually have a double effect on those two negative factors that are risk for thrombosis. We increase the synthesis of TPA, the storage and release, so it's ready if you have a bleed and a clot forming, and we also reduce pi in the bloodstream. And the beauty of this approach is that we are not weakening the coagulation system. The other drugs do that 24/7, so you're walking around with that risk. Our drug you take in advance, you build up the storage of TPA, and you reduce pi, so it's not very high in the morning hours. If you get a bursting plaque, you have your defense mechanism active. And it only acts locally. So TPA is only released where you might get a bleed from a bursting plaque. So if you get a small bleed in the brain and a forming clot, or you get it in the heart or somewhere else, you have TPA there and the body releases it itself. So our objective is to develop this drug and provide it as an effective and safer medication in preventing thrombosis. And the major indications are VTE, myocardial infarction, and stroke caused by atrial fibrillation. Now, the researchers here have found this substance. It's a substance that's already on the market for epilepsy, VPA. And they put this into a number of studies. I'll show some results here. So here you see the results from aorta in mice. They're treated with the substance. And you see the control group is red, so it's the endothelial cells. And the treated group has much more green. The green is TPA, the fibrinolytic substance that you want to have present in your body if you get a blood clot forming. This is our proof of concept in animals, in live animals. They have been pre-treated for 3 days, so 72 hours. And the black line is the control group, and the red line is the pre-treated mice. They were hurt in a vessel to see if we could prevent the thrombosis formation. And as you can see already after 2 minutes, you have a protection here. And you can see on the blood clot here, the thrombosis is much smaller in the pre-treated group. So we are preventing the thrombosis from growing in live animals with this pre-treatment. This is in man. We've shown that we can affect these 2 biomarkers. We have increased the release of TPA in a 4-hour model in patients, 2 weeks treatment, and we have also reduced pi with 50% in these patients. Very interestingly, a study came out, because you wonder, will this really work in man, when we have the drug ready? And that's up to us to prove. But this is a study in Denmark on the whole Danish populations, 150,000 patients retrospectively, 10-year follow-up. They looked at all the epilepsy drugs that were used, and they found something very interesting, that there was a 40% lower risk of myocardial infarction if they were on this substance, this epileptic substance, VPA. So it looks like it's preventing thrombosis in man. There's been 2 other studies. An Irish study did a similar kind of work, epidemiologic work, and repeated the results. And this year there was published a Scottish study, prospective study in stroke with similar kind of preventive data. I don't have time to go into it here. So we have reformulated VPA into a formulation that will suit this patient group. It's an advanced control release formulation, delayed immediate release formulation, to take care of pi in the morning hours, and also make sure that TPA is available in the endothelial cell wall. We did a study in phase 1, and the results was as expected. So we showed good safety and tolerability, the pharmacokinetics that we were after, and we also lowered pi significantly in the morning hours. So now we want to do a phase 2 trial to have proof of concept in preventive concept efficacy in man. And we have signed a financing deal to support the financing of this study. It's a big study. So it's 20 clinics, Russia and Bulgaria, and we will, and the same kind of model that Big Pharma has used, and we want to show prevention of thrombosis in orthoplastic surgery, total knee replacement actually. Now, very good news, we got patent approved in end of October in the US, the biggest market here, make up about 50% of that 20 billion that you saw. So this is the key milestones that we have achieved so far this year. So we secured financing, 80 to 106 million, phase 1 clinical trial with great results. We signed a CRO after procurement, international procurement, to do the trial. So we have a contract to do the phase 2 trial. New medical director and the board, the person responsible for late-stage clinical trials for the Roche concern, Anders Svensson, joined our board this fall. And now we're putting the papers together, the documentation to get approval to start the study. And we're scaling up the substance or the drug for the clinical trial. So these are the upcoming milestones. Scale up, submission. We'll submit this spring, before the summer is our plan. And we'll start the study after the summer, sometime, when we have the approval in Bulgaria and Russia, and we'll complete it at the beginning of 21. So, as I mentioned, there is a need for new therapy because it's very risky, but that's what we have. Now we might have something that's less risky and effective and actually utilize the body's own defense mechanism. And that's CS1, that's what we call the drug. Looking at the market, this is the projection of the market. So when we hit the market, approximately 24, 25, the market will be $13 billion in these markets here. And we will be alone unless somebody else figures out how to do this next to us and compete. Hope you found it interesting. Thanks a lot.
Thank you very much still. Tight program, so I will instruct everyone to ask your questions to stay at the lunch break.
Thank you.
Yeah, thank you very much. So from cancer diagnostics to women's health to cardiovascular diseases, we're going to move back into oncology, specifically immuno-oncology. And I'm very happy to present you Per Norlén, CEO of Alligator Bioscience. Welcome, Per.
Yeah, thank you.
So, thank you. Alligator is a Swedish clinical stage immuno-oncology company. And that essentially means we are doing the same thing as everyone else. We are developing therapeutic antibodies, activating the immune system towards cancer. The one difference is that all our products are developed to induce a strong immune activation in the tumors, but not elsewhere in the body. And the point is, of course, to focus the immune attack towards the tumors and reduce systemic side effects. This is called tumor-directed immunotherapy, and it's an area pioneered by Alligator. We have 5 products today, from preclinical to clinical development, all with the first and best-in-class potential. And the quality of our products has been validated through a major out-licensing deal with Johnson & Johnson worth $700 million. Based on that front of that deal, and the first milestones, we have a very healthy cash position as well. Money in the bank to take the company more than 2 years from today. And our business model is to develop our products within tumor-directed immunotherapy from ID all the way to clinical assessment in patients. And what's slightly unique about Alligator is that we have already delivered on this model. So let's take a look at the deal with Johnson & Johnson. We have a deal of $700 million. We have received $46 million to date, upfront and first milestone payments. And it's an excellent structure of the deal, more than $350 million in development and registration milestones, and the rest as sales-based milestones. On top of this, we have tier royalties in the range of 10% royalty on all potential future sales, starting below and ending above 10%. Plus, they take all costs for the development. So this is a fantastic deal for an early phase 1 asset. We have today completed 1 clinical trial, a phase 1 trial, demonstrating that we well tolerated at clinically relevant dose levels. And that trial was completed by Alligator. Then Johnson & Johnson, or Janssen Biotech, which is a Johnson & Johnson company, has started another phase 1 trial. They have expanded it to systemic administration. That trial has today included more than 80 patients, and they are about to select a dose for the next stage, which is combination with the PD-1 blockers, other immuno-oncology products. And I just mentioned that Janssen takes all further clinical development and they take all further costs. So let's look at the competition here. We are not alone, it's a significant competition, but we are at the front and we have a very strong partner, Janssen Biotech of Johnson & Johnson. Also, we have a strong preclinical evidence that we have a potential for a best-in-class profile. Based on the fact that we developed this for tumor-directed immunotherapy, we seem to have a very good tolerability profile, and that will allow dosing at clinically relevant dose levels, which has been the issue with CD40 agonistic antibodies. So we're at the front, and with a strong partner and a very good profile. Now, Johnson & Johnson will take all costs, so we can focus our resources and our time on the next clinical asset, which is a very important asset, 81015. What we have developed here is a completely new concept. We are first in the world with a tumor-localizing CTLA-4 antibody. And why that's important is because a CTLA-4 is a clinically validated target, but it's limited by toxicity. And it's also a combination therapy in one product. We have fused an OX40 immune activating antibody with a CTLA-4 blocking product into a bispecific antibody with dual effects, all with the purpose of generating superior efficacy. And we can do that by activating both the T effector cells, the main tool of the immune system, and also suppressing the regulatory T cells. So, in other words, we can step on the gas and release the brakes at the same time with this molecule. But that's not all. We are actually hoping to get a better effect than combining OX40 and CTLA-4 at the same time. And we can do that by not only activating both pathways, but also we can bring them together, creating a physical bridge between the two receptors, between cells carrying those receptors, increasing immune cell crosstalk. And it works. Let's look at this as a great example. Here is a key mechanism of action, which is suppressing the regulatory T cells. We can look at the blue line, which is a maximum effect you can get achieved by combining OX40 and CTLA-4 antibodies at the same time. But 1015 carrying those two targets has a fourfold better efficacy. Now, let's have a look at CTLA-4. I say it's a clinically validated target. Yervoy, the first immuno-oncology product to be approved, was approved in 2011. It was soon followed, it is the orange color here, it was soon followed by the PD-1 blockers. They had even stronger activity, plus they were better tolerated. So it's been a huge success. PD-1 blockers will sell, this last year they sold for more than $10 billion US, whereas CTLA-4 in the range of $1.2 billion US. And they will continue to increase up to about $40 billion US within 5-6 years. Yervoy will not continue to increase in that. It will increase a bit, but not at all that much. And there is one key explanation. It's very toxic. So then you will ask yourself, why would we take the trouble to develop another CTLA-4 blocker, a stronger CTLA-4 blocker? It will just cause more problems. Well, we have a beautiful solution here. This is a tumor-directed immunotherapy. It's a tumor-localizing CTLA-4 antibody with stronger efficacy. And let's take a look at the data. Here is a key result. We look at the immune activation in the tumors. If there's no therapy, there's very low immune activity. We can increase immune activation through OX40 antibodies, by CTLA-4 antibodies. But as you can see, again, 1015 is far more potent. But what's really important here is that this effect is exclusive for the tumor. In other parts of the body, the immune system is not affected whatsoever. So here it seems we can provide superior efficacy with the potential to avoid the systemic toxicity. Let's go back to the sales of Yervoy. Last year, it sold basically only in melanoma, $1.2 billion. It's a quite small population, 25,000 patients. And only 1 out of 4 patients take the drug, despite the fact that they know they will have a better chance to survive if they took it. And that's because of the toxicity. Last year, it was also approved in lung cancer. It's a 10 times larger population. Still, it will be a bit limited by toxicity. Sales will increase, but we don't know how much. Now, 1015, we have a potential both for superior efficacy, but notably superior tolerability. And of course, if we can show that, we have an increased market size and also better penetration. And what's really good for a product coming up for clinical development is responder populations have been identified through the development of CTLA for the last 8 years. We know it's effective in melanoma. We know it's effective now in lung cancer. It's also effective in colorectal cancer with high mutational burden. So we know where to study the product. And the studies have been started. We have started the first clinical trial in December last year. It's a first-in-human trial, intravenous administration, dose escalation from low doses to high doses, about 50 patients to be included, and the primary endpoint here is safety and tolerability. And in this case, it's really, really important because that will demonstrate our concept. This trial will have a safety readout second half of next year. But before that, we will actually initiate the phase 2 trials. As soon as we have a dose, which we expect to have in about 18 months, mid next year, we will start the phase 2 efficacy trials to demonstrate efficacy in combination with PD-1 in melanoma first, but in parallel, we will also initiate studies in lung cancer and in colorectal cancer with high mutational burden. So, just a short on our finances. I said we have a good cash position, and this will allow us to take the company forward, all our development, all our products, for more than 2 years. And on top of that, obviously, we hope to get more milestones for 1013, and also we have a number of products with potential in out-licensing income. So a summary of the products we have, 1013. Here we have a great partner. We have a unique target with CD40. We are at the front, and we have a potential with the best, we believe we have a best-in-class profile of the product. 1015 then just started clinical phase 1, and we are first in the world with a completely new concept here, a tumor-localizing CTLA-4 product. And if we can demonstrate the concept in our first clinical trials, this has a great blockbuster potential. Then we have 2 products coming up from behind, 1017 and 527. They will both close in on clinical trials this year. 1017 will start clinical trials, and we will submit for clinical trials for 527 this year. So by that, we are building a solid clinical pipeline within our niche of immuno-oncology, which is tumor-directed immunotherapy. Thank you.
Do we have time for a couple of questions?
Sure.
Yeah.
Let's
Let's step up. Yeah. And I'm going to join you here, so it's really crowded. So this all looks really impressive, of course. You have like you said, you have a solid pipeline. You have a partnership with a big pharma company, and you're building your pipeline quite strategically, it says. Being first in the world with something, that's not always a good thing. But in your case, you do have like it's a proven concept.
Yes,
so to
and that's what makes it so much better, that CTLA-4, we know it should have efficacy. That's been clearly demonstrated. So it's mainly about demonstrating safety. Then we obviously need to confirm efficacy. But we know where to do it and what patients to do it. So it's a much, much more limited clinical development plan.
Yeah.
If you take another immuno-oncology target, any target, even our 4-1BB targets, no one knows where they are most effective. So you need to study much, much more broadly, and that's obviously much more expensive.
Also think it's really interesting that where your molecules, where they're coming from. You have an interesting platform technology.
Yes.
Tell us a bit about that.
No, that's correct, and I didn't mention our technology platform today, but we are a technology-based company. We were founded on the technologies, and we have today a full technology platform. Every technology we need to generate the next generation bispecific immuno-oncology antibodies, and that's human antibody library. We can select any therapeutic antibody. We have a protein evolution technology, FIND, where we can optimize any property, and also we have actually today 2 bispecific formats. And maybe you're commenting on, we had a press release last week on a new bispecific format,
Exactly.
Ruby, where we can fuse any two antibodies into a bispecific antibody format.
And how common is that?
There are a number of such formats out there. The problem is with them is that they usually demand a lot of optimization. Well, you can fuse antibodies, anybody can do that, but the key is to fuse them and then have a developable product.
Oh, yeah.
It could take 1, 2, 3 years to make it developable, but with our format, we can cut that down and we don't need the secondary optimization. So it's a much, much faster process.
Sounds convenient. I should see, are there any questions in the audience as well? If not, then we are actually going to thank you, Per, for now, and you're free to grab Per at lunch. Let him eat, but if you have questions, we are going to take a short lunch break. So thank you very much, Per.
Thank you.
So we will take not a short lunch break. We'll take a normal lunch break, around an hour. So we'll see you back here around 12:30. We will start the next session of after lunch with a keynote speech from Nasdaq's representative, Carsten Borring, which will be very interesting. He will give us an update on the market sentiment. So see you back there for that. Thank you very much.